Good evening, dear colleagues and friends. Welcome to the ESGE Wednesday webinars. I'm Professor Konstantinos Triantafyllou from Athens, Greece, and together we will watch a nice webinar on the endoscopic management of two specific motility disorders. Hopefully you will enjoy it. As you already know, this is the fourth consecutive year that ESGE gives you the opportunity to view high-quality presentation on the hottest topics in endoscopy from world leaders in their field. During this presentation, during these webinars, you can interact with the speakers and participate by submitting online their question. I'm quite sure that you are familiar with the tool, the Q&A tool that you can see on the bottom of your screen. And of course, this activity is still free. It's my pleasure today to introduce two exceptional participants. It's Professor Jan Martinek from Czech Republic, from Prague. Welcome, Jan. And Professor Bas Weusten from Utrecht in the Netherlands. Welcome, Bas. It's a pleasure to have you with us and to discuss this very, very interesting and very new topic. I mean, in the literature, I think, especially in the guidelines chapters of the ESGE, we will discuss cases and the guidelines on this topic. So it's my pleasure to introduce Professor Bas Weusten, a key opinion leader and a key investigator, also a key author in upper GI disorders, especially in esophagus. So Bas, thank you for accepting the invitation, and we're looking forward to see your presentation.
Thank you very much, Kostas. It's my pleasure to be panelist in this webinar, and here are my disclosures. I've got a few introductory slides. 3 years ago, the ESGE Guideline Committee initiated a guideline on the endoscopic management of gastrointestinal motility disorders. And the working group identified 6 disorders, motility disorders, in which endoscopy played or could play a role. Achalasia, gastroparesis, Zenker's diverticulum, gastroesophageal reflux disease, intractable constipation, and Ogilvie syndrome. Well, those 6 subjects were too much to be covered in one paper, so we split it up into 2 parts. Part 1 of the guideline on endoscopic management of motility disorders is dedicated to achalasia and gastroparesis, and these 2 disorders, as Kostas already mentioned, will be the subject of today's webinar. But I really invite you to also check out the second part of the guideline, which is also highly interesting, I think, on Zenker's diverticulum and the other motility disorders. While we were working on this guideline, there was a simultaneous process by the UEG in combination with the European Society of Neurogastroenterology and Motility, and they prepared a guideline on achalasia. And well, we did it in close collaboration. So these 2 guidelines, the one of the UEG published and the one of the ESGE, should be considered complementary guidelines. And I also advise you, if you're interested in achalasia, to read that guideline as well. Having said that, it's my pleasure to handle the microphone to my friend and dear colleague Jan Martinek, and he will guide you through the achalasia part of this guideline. Jan, the floor is yours.
Thank you, Bas. It's my really great privilege to be part of this webinar and to present you 2 patients suffering from achalasia and to discuss with you their treatment options and to discuss the practical implementation of now mentioned guidelines. So I will present the first case. Here is my disclosure. And we have 66 years old patient, male, with the achalasia type 2 with Eckhart score being 6, predominantly suffering from dysphagia, being at 3 points, regurgitation, 3 points, no pain, and no weight loss. There is a question to all participants: what treatment would you recommend for this patient? Botulinum toxin, POEM, laparoscopic pyloromyotomy, pneumatic dilation, or the last possibility, the B plus C or D, all are right answers. Please, now you will be able to vote. So 46% voted for the last possibility, that POEM, myotomy, laparoscopic, and pneumatic dilation are all right answers. And the second was 26% POEM, 15% PD, and few of you would consider laparoscopic myotomy. Thank you for showing the pool, and I will gain control again. According to the guidelines, the right answer is E. It means that POEM or laparoscopic myotomy or pneumatic dilation, all these treatments can be offered to a patient suffering from achalasia type 2. So in general, we have 4 options how to treat patients with achalasia: botulinum toxin, pneumatic dilation, POEM, and laparoscopic pyloromyotomy. I would like to underline that stents are not accepted principle for treating patients with achalasia. And if we look at if you look at the guidelines, they say that botulinum toxin is effective and safe therapy for short-term symptom relief in achalasia. It means this treatment should be really reserved for old or polymorbid patients. Graded pneumatic dilation is an effective and safe treatment for achalasia. POEM is also effective and safe treatment for achalasia, as well as laparoscopic pyloromyotomy combined with an anti-reflux procedure is an effective and relatively safe treatment for achalasia. And also the guidelines say that we suggest age and manometric subtype should be taken into account when selecting a therapeutic strategy. And overall, graded pneumatic dilation, laparoscopic myotomy, and POEM all have comparable efficacy. If I take it simple, we can generalize that for type 1, PD, POEM, and laparoscopic myotomy all are acceptable and comparable treatment options for patients with type 1. The same applies for type 2. And only in type 3, there is enough data to consider peroral endoscopic myotomy as a first choice treatment, having some advantages over both laparoscopic myotomy and pneumatic dilation. PD has comparable efficacy to laparoscopic myotomy and POEM, but there is an important point that patients have to accept that repeated treatment sessions are often necessary along the course of the disease. As long as the patients accept this fact, PD is considered as an effective and safe treatment for patients with achalasia. Back to our case, this is the manometry. So we see, we don't often see such a high pressure of pressurizations reaching the red color. For those who are not familiar with manometry, blue color is no pressure and red color is very high pressure. We see the not relaxing sphincter, lower sphincter, and here are pressurizations reaching sometimes really very high values, some signs of even spasm, but we classify this patient as having achalasia type 2. We don't routinely perform EUS, but this patient underwent EUS showing very thick muscle layer, and his IRP was very high, 70 millimeters of mercury. Normal value is 50. So back to the question, the E is right answer. The POEM was chosen by this patient, and we think POEM is a reasonable choice. The patient has some longer history that he already presented in 2017 with achalasia type 2. As you see, IRP was 25 at the time, and it was a pain dominant, predominant achalasia. And we offered him these 3 treatments options, but he chose wait and see strategy. Next year, there was symptomatic improvement. ESGE score was only 2, and he chose also wait and see strategy. But this December, he presented with symptom deterioration with the values I already showed to you, and we offered him these 3 treatments. He chose POEM. Now I will go through the POEM procedure to show you some technical aspects and pre and post-op management of this patient. The patient came to the hospital day before the procedure, and we always check the health status by performing ECG, measuring blood pressure, checking all the values. It's really important because POEM, even endoscopic, is a surgical procedure with under general anesthesia, and we must be sure that our patients are fit enough to undergo this procedure. We usually perform control endoscopy. The main aim is to clean the scope and to exclude, to rule out candidosis. If there is a candidosis, we administer appropriate treatment. And the patient is given nil per month. And day of the procedure, 30 minutes prior to POEM, we administered ceftriaxone 2 grams and metronidazole 50 milligrams plus omeprazole intravenously. Our guidelines recommend the prophylactic perioperative use of antibiotics when performing POEM. The choice and duration should be adapted according to national or local protocols. Here you see the start of the procedure, the esophagus, which is free of esophagitis, free of candidosis, spastic cardia, and we can do POEM either on the posterior side or the anterior side. As you see below, the ESGE recommends that POEM can be performed on either anterior or posterior side. Theoretically, the POEM can also be done on the greater curvature side, but this is not the standard location. There are studies showing that these 2 approaches do not have any differences in terms of effectiveness or adverse events. And me personally, I do majority of POEMs now on the posterior side. The next video show you short incision. We do now really short incision because it's easier to close it. And incision is done by using TT knife and endocut current. There's dissection of just along the margin of the incision, and you will see how we get inside the below the mucosa and how we start tunneling. The tunneling, we use TT knife, but once we are inside the tunnel, we switch our current to coagulation, current spray coagulation. The vessels, small vessels, as you see here, we coagulate by using knife, which is kept inside the sheet. The larger vessels, we coagulate by using a grasper. And the aim is really to do a long tunnel, especially with an extension 2 to 3 centimeters below the cardia. How to recognize that you are deep enough? First, that the area of sphincter is nicely recognizable. And second, there are the special cardiac vessels, spindle vessels shown here or here on the pictures. And this is the sign that you are anatomically already in the stomach. ESGE does not recommend lavage of the submucosal tunnel with antibiotics. Several centers used to or are using the irrigation of the tunnel before starting myotomy with antibiotics, there is one study showing that it does not bring any benefit. Now it's a myotomy. Once the tunnel is completed, there is a myotomy. Here you see how we start the myotomy on the posterior side. I coagulate the circular fibers to get really the appropriate depth. It means to see the longitudinal layer, as you can see here. And this is my plane. I continue my myotomy. The myotomy, the mean length of myotomy in our hands is now around 10 to 12 centimeters. And you see how we perform this myotomy. This is, if you do posterior side, the diaphragm. And there is an extension into the cardia 2 to 3 centimeters, as you can see here. This patient really had rather thick muscle layer and the end of myotomy. ESGE recommends in POEM extending the length of myotomy 2 to 3 centimeters into the gastric side of the cardia. It is really important point to have good and long-term effect. To perform full or partial myotomy, it's important to note that majority of studies perform full myotomy. It means splitting up both circular and longitudinal muscle layer. As you can see here, this is adventitia, and full myotomy is considered the current reference technique. Only some tips and tricks. There are two ways how to perform myotomy. First is cutting, as you can see here. So I go with a knife beneath the muscle and I cut. And this is the technique which I personally prefer and I do if possible. You must really be careful not to cause injury of the mucosa here. And the second technique, also used by many endoscopists, is rather coagulation, which will be seen on the second video here. So I am not cutting the muscle, I am approaching with my knife and I'm coagulating. I think both techniques are possible, and sometimes I also use this coagulation technique, especially if there is not enough space in the tunnel. The final step is closure, incision closure. In this patient, as we created a short incision, we needed only 3 clips, and we use only clips to close our incisions. And there were 2 patients out of our 400 patients we treated with POEM who needed some rescue methods, either by using Apollo or Ovesco clips. So clips generally are very safe and effective. These are high resolution clips in this particular case. If you do longer incision, you need more clips, and the short incision is really our standard practice. What is important to look at during the procedure is inspiration pressure. It's usual task of an anesthesiologist. And here you see that during the procedure, we reach the inspiration pressures above 30 millimeters of mercury, 34. And if there is abdominal tension in the abdomen, we perform puncture by using standard cannula to decompress capnoperitoneum. We use this in about 40% of our patients, and we never had any complication by doing this. In very sick people, we use Veress needle to be really safe. In standard patients, we use this venous cannula, as you see here. The important point is also post-POEM reflux, that after POEM likelihood to take PPIs is 50% according to this randomized study. But after laparoscopic myotomy with fundoplication, the need to take anti-reflux medication is almost 30%. It means not 0. But the guidelines recommend that follow-up endoscopy to screen for GERD should be performed in all patients treated with myotomy without anti-reflux procedure. And proton pump inhibitors are the first-line treatment for GERD in patients who underwent POEM. And in patients with esophagitis more severe than grade A, they should get long-term therapy. In our institution, every patient is given esomeprazole twice a day for 30 days, then on demand. At 3 months, we do pH metry and endoscopy, and we base our further treatment decision on the results of these two examinations. If there is no esophagitis, proton pump inhibitors are given on demand. In case of esophagitis, they have lifelong treatment once or twice daily. In case of severe esophagitis, patients are given high dose of PPIs and we perform yearly control. Back to the case 2. This is young male, 37 years, standard achalasia type 2. What treatment would you recommend for this patient? The same question. A, botulin toxin, B, POEM, C, laparoscopic myotomy, PD, or all POEM, laparoscopic myotomy, and PD are all right answers. Please vote. And now we will see the results. We get quite similar results as in the first patients. The majority voted the option E, B, C, and D are all right answers. So I can take control again. And I think it's really, as I already mentioned, it's achalasia type 2, B, C, and D all are right answers. This patient presented in 2019. His EGHAR score was 7. IRP was 35 millimeters of mercury, and endoscopy showed decompensated disease. He was offered POEM or laparoscopic myotomy or PD. I think this is very important to offer our patients every option. He chose PD because according to the patient, it is quicker and simpler, and we offered graded pneumatic dilation. Here is the manometry with not relaxing sphincter. And now is the last, my question, what balloon size would you start PD with? 30, 35, or 40? Please vote. Yeah, I think it's right answer. 86% of you would start with 30 millimeter of balloon, which is really the right way. So I can get the control back. According to the ESGE guidelines, the graded PD should really start with 30 millimeter balloon. So graded PD protocol in achalasia is recommended starting with 30 millimeter dilation balloon, followed by 35 millimeter dilation at the planned interval of 2 to 4 weeks. The subsequent 40 millimeter dilation is recommended if necessary. And this approach is preferred one over both a single balloon dilation procedure or the use of a larger balloon from the outset. Here you see the video of the procedure, decompensated disease, and we performed PD both under X-ray and endoscopic control. We introduced the balloon, 30 millimeter balloon, over the guide wire, and here through the balloon you see the waist, which is also seen on the X-ray. And the aim of dilation is to get rid of this waist, to flatten the waist, which happened here. Here you see the balloon with no waist, and at the end we check the cardia to rule out the perforation. Because the patient had immediate and complete symptom relief, he refused the second session, and at present his EGHAR score is 2 and he is quite satisfied. So we plan a dilation or any other treatment in case of a relapse. So again, the recommended approach is to start with 30 and to go in 2 to 4 weeks to 35, and if needed to 40, 2 to 4 weeks interval. And note 35 millimeter balloon at the beginning because there is a high risk of perforation, and no single session of PD, but some patients we must be ready for that, will refuse the second session of dilation. In our department, we do this procedure either we keep the patient 1 day in a hospital, or we do it also as an outpatient procedure. X-ray we don't do routinely. We use a sedation, midazolam, and fentanyl. And what is really important, that the inflation should be very slow. We inflate to reach the pressure of 5 per square inch, 45 to 60 seconds, and we keep this pressure for 1 minute, and then we increase the pressure to 8 to 10 per square inch, and we keep it for another minute. We never go over 10 per square inch. So I went through the 3 treatment options, PD, POEM, and laparoscopic myotomy. It's really important to explain to patients advantages and disadvantages of each of these treatments. And according to guidelines, therapy decisions should be based on local operator expertise and, importantly, patient choice. Every patient should be informed about all treatment options. Thank you for your attention. And I will ask Bas to continue his case with gastroparesis.
Thank you, Jan. And I will start with a case. And my case is a 65-year-old female patient who back in the days was referred for residual squamous cell cancer after an endoscopic resection performed in another hospital, which was not radical. And I performed an EOS, and I recognized that there was a lymph node at the celiac trunk, which after FNA proved to be a lymphatic metastasis. So she underwent a thoracolaparoscopic esophageal resection after neoadjuvant chemoradiotherapy in November of 2016. And the post-operative period was uneventful. She visited my outpatient clinic because of symptoms of fullness, nocturnal regurgitation, and also inability to eat sufficiently large meals. And those symptoms were already from the start of her recovery period after the operation. And endoscopy, there was a significant food retention in the gastric tube, although she didn't eat for 12 hours prior to endoscopy. So this is really food retention in the stomach. And I have a question for you, Paul. And the question is that delayed gastric emptying after esophagectomy is caused by all the items mentioned below, except one of these. So 2 of these do cause delayed gastric emptying, and the other one not. So the question is, do you vote for a vagotomy-induced enteral hypomotility? Is that one? Is that an exception of the causes? A vagotomy-induced tachygastria or a vagotomy-induced pylorospasm? So it's a little bit a difficult question in terms of how I put it. So one of these 3 is false. That's so most of you answered that vagotomy-induced tachygastria, I must say, is not a cause of delayed gastric emptying after an esophagectomy, which is completely right. So that is very good. Let's move on, because there are many factors involved in gastric motility. It is not only the gastric electrical activity, which originates from an area approximately here in the stomach between the fundus and the corpus of the stomach, from interstitial cells of Vagal. It's a sort of gastric pacemaker, controlling the electrical activity of the stomach in a 3-per-minute cycle, and superimposed on that, enteral motility can take place. And whether or not there's enteral motility, that is guided also by the vagal nerve. And there's the pyloric function, of course, but there are many other factors. Of course, if there's a problem in the myocytes, then you can expect a delayed gastric emptying, but also neuropathy, of course, is a well-known cause, either diabetic or other causes of neuropathy. There are also many hormonal and paracrine factors involved in gastric motility. And if there are important electrolyte disturbances, such as an hypocalcemia, you can get a decreased gastric emptying. Glucose level is a very important factor, and a hyperglycemia will cause an acute delay in gastric emptying. So gastric emptying tests should be performed on a normal glucose level. That's very important to realize. Viral infection can affect gastric motility. Drugs, very important, and of course also psychological factors. The vagal nerve has an important role in gastric function. There is a vagal control of the enteral motility, and there is a vagal control of pyloric function. And if there's a vagotomy, and all esophagectomy patients do have a truncal vagotomy, of course, then both factors can be disturbed. Both enteral motility can be decreased and pyloric function can be disrupted. And of course, with endoscopic therapies, we can only do something at the pyloric level and not on enteral motility. That's also important to realize and to tell to your patients. The vagal nerve also controls the fundic relaxation, as you know. When you ingest a meal or when you think of ingesting a meal, there's a fundic relaxation, and that enables the stomach to accommodate the meal. And that is why after an esophagectomy or other causes of a vagotomy, you not only can get a delayed gastric emptying, but you can also get an accelerated gastric emptying, especially for fluids, causing dumping symptoms. And that is also important to differentiate when you face a patient on your outpatient clinic. There are several conservative measures you can take when you face a patient with gastroparesis. And first is that you should eliminate factors associated with the delayed gastric emptying. Very important. Please review the medication the patient takes, and also, if a patient is diabetic, control the hyperglycemia. That's the first step. Dietary measures can also be taken. There are several dietary factors which decrease the emptying rate of the stomach. Fibers are good for everything except for your gastric emptying. That will delay your gastric emptying. High fat in the meal will also delay gastric emptying, as do alcoholic beverages. And in patients after esophagectomy, it's wise to advise not to eat meals 3 hours prior to sleep, because otherwise they have an increased risk of regurgitation and aspiration. And of course, I suggested all of these advices to my patient, and she came back to my office and she said, well, your advices were completely useless. And she added, as always. So what would be the next step here? We could go to Pylorus-directed therapy, prokinetics, gastric emptying testing. So that's the next question to you. In a patient with insufficient symptom relief in gastroparesis, so where do we go? Can we go back? Not really. Maybe we can. Yes, there we are. Because otherwise the poll doesn't make any sense. In a patient with insufficient symptom relief of conservative measures, what is the next step? Is that a Pylorus-directed therapy, or is it gastric emptying testing, or prokinetics? So I hope we don't switch between these screens anymore. So now we can see what you answer on this question. So now you've got the possibility to vote. And here you see that the ideas are a little bit diverse, and I must admit that there's not a real false or correct answer here, but maybe we can shed some light here. Well, the ESGE recommends that endoscopic therapy directed to the pylorus should only be given or offered to patients with symptoms of delayed gastric emptying combined with an objective proof of delayed gastric emptying, and only after medical therapy has failed. I hope that the technical staff of this webinar can hide the poll, because otherwise the slides will be difficult to read. And I know they are quite busy with this, trying to solve it. Yeah, there we are. So there are three items here. Symptoms suggestive of gastroparesis, an objective proof of delayed gastric emptying using a validated test, and only after medical therapy have failed. Well, let's review it. I would like to draw your attention to the Gastroparesis Cardinal Symptom Index, which is a more or less standardized way to assess symptoms in this difficult patient category. It is a questionnaire, a self-reporting, so to speak, on several items: nausea, retching, vomitus, stomach fullness, not able to finish a normal sized meal, excessively full feeling after meals, loss of appetite, bloating, and visibly larger stomach. And those should be reported over the past 2 weeks. And I think it's useful to use this index because it enables you in a more or less standardized way to analyze or to see the effect of your interventions. And of course, it's a tool frequently used in studies. But what is an objective proof of delayed gastric emptying? Well, if you have an endoscopy in an appropriately sober patient, so a patient who didn't eat for 6 hours, then you can say that the gastric emptying is significantly delayed. Gastric scintigraphy is, I think, the gold standard, and the most reliable item is the percentage of meal retention after 4 hours. And then you can grade the delay in gastric emptying into 3 categories: mild, moderate, and severe, depending on the percentage of the meal retention in the stomach. There's also breath testing, and even a motility capsule can be used as an objective proof of delayed gastric emptying. For this particular patient, however, it is important to realize that for gastric pull-ups, there's no validated test of gastric emptying. Well, prokinetics. We've got a few options: dopamine antagonists, domperidone, metoclopramide. Metoclopramide is not a good solution for long term in my eyes because it has got significant neurological side effects. Erythromycin is of course well known for its acceleration effect on the gastric emptying, but there's a significant tachyphylaxia, so there's a loss of response already quite soon. And prucalopride is a relatively new kid on the block, more or less similar to cisapride, which we used to use 20 years ago, but there is no registration for this indication, and there's little evidence that it's helpful. So there are little data, and in my experience, and I think in most of your experience, in patients with real gastroparesis, the effect of prokinetics is disappointing. So then we can proceed to Pylorus-directed therapy, and we've got several options: transpyloric stenting, pyloric balloon dilation, botulin toxin injection, surgical myotomy, of course, but that's not an endoscopic treatment, and endoscopic pyloromyotomy, also called GPOM. let's very briefly review those options. For the transpyloric stenting, the ESGE recommends against the use of transpyloric stenting because of the relatively high complication rate. So it's not very safe, it's not a long-term solution, and it shouldn't be done. Pyloric balloon dilation, well, the ESGE suggests not to use balloon dilation in the treatment of unselected patients with gastroparesis, and this is a very delicate description, as you can recognize. And the reason why this is recommended as such is that there is surprisingly little evidence on the efficacy of this treatment, especially in the long term. But on the other hand, if you have no other alternatives, it could be done. And if you use pyloric balloon dilation, then you can choose for either a water-filled balloon of 20 millimeters or a pneumodilation balloon of 30 millimeters, the same as you used for achalasia treatment. So this is a weak recommendation. Botulin toxin injection in the pylorus is relatively well studied in contrast to the other options I mentioned, and the initial reports were promising, but there are 2 randomized trials, and those 2 randomized trials are negative. Surprisingly, there might be a type 2 error, so it's not very large studies, but the results were not in favor of botulin toxin injection. So the ESGE recommends against the use of botulin toxin injection in the treatment of unselected patients with gastroparesis. However, most experts will agree that there is a subset of patients who really do respond on botulin toxin injection, and sometimes it can be used, although there is a theoretical disadvantage that it might interfere with subsequent endoscopic pyloromyotomy. As we know, it is the case for Botox injection in the lower esophageal sphincter in case of achalasia. Of course, it's only for short-term relief. It's not a lasting solution. So the prokinetics in our case was without any benefit for the patient, and she was treated with Botox in the pylorus with a good symptomatic response, but she relapsed as expected after 8 months. That's the time period you expect Botox to fail, and the Botox injection was repeated. So then she came to my office and said, well, I want a more definite solution. And well, a definite solution could be a J-POEM, endoscopic pyloromyotomy. And the ESGE recommends consideration of J-POEM in carefully selected patients only, because it's an emerging procedure with limited data on effectiveness, safety, and durability. J-POEM should be performed in expert centers only, preferably in the context of a clinical trial. And I think the latter is very important because we really want to gain more information on this treatment, and we can only get more information if we perform our treatments in the context of clinical trials. Well, how to select patients for J-POEM? It might be reasonable to think that a good response on botulin toxin injection would predict a good response of J-POEM, but there is little evidence to support it. So the ESGE recommends not to use botulin toxin injection as a screening test to select patients for J-POEM or other Pylorus-directed therapies. Also because of the potential downside of inducing fibrosis after botulin toxin injection, which might hamper subsequent J-POEM. In this video, I very briefly summarize the J-POEM, and then we can discuss the items, the technical items of J-POEMs in the next slide. So you saw the pylorus, and you saw that I injected some saline in the submucosa, And then you see here that I created a mucosal incision, and now I try to get into the submucosal space. It's quite similar to the example of poem in the achalasia case that Jean Martinek showed you. And you see, you can appreciate that the submucosal fibers here are very transparent and very loose and easy to see. Of course, when you perform the tunneling technique, you once in a while have to inject some additional fluid, and then you can dissect further towards the pylorus. I also use the triangular tip knife, as Jan also showed you in his achalasia case, and also use the spray coag. And this is the moment where you can appreciate the pyloric arch. It is, if you have the right direction in your tunneling, it is not easy to miss the pyloric arch. So it's always visible. And once you've reached the pyloric arch, this is where it's all about. It is the transection of the pyloric muscle. And if you perform a J-POEM, of course, you should do it rigorously. So it really should be a complete myotomy. Otherwise, all your efforts are in vain. So you can also appreciate that the pyloric muscle can be quite thick. You can see the margins of the pylorus here, which is already a cut. So it's a quite deep cut here, but I have to cut deeper to get a complete myotomy here. And this is the final fiber of this part of the pylorus, which is cut here. So, and just like the poem, of course, the final step is the closure of the mucosal entry. And afterwards, you can assess the effect on the pylorus and check if the mucosa is completely intact. Here you see the clips. Quite bumpy because of the heart beating. So if we review the J-POEM step by step, of course, the stomach should be empty. And I always advise patients to not ingest solid food for 3 days prior to the J-POEM. And then you can assess the pylorus. And it must be said here that it is sometimes the case that now you can see a closed pylorus, but sometimes it looks quite open, and it is not a predictory factor whether a J-POEM would be effective or not. We always administer IV prophylactic antibiotics during J-POEM, and the choice should be, of course, be according to the national or local protocols. The next step is the injection, creating a submucosal bleb. I do it with saline with a little bit of indigo carmine as a dye solution, and then the mucosal incision. The location could be anywhere in the antrum, basically, but it's most easy to perform it at the posterior side of the antrum or the greater curvature. The length of the mucosal incision, well, I tend to not to make it too small, because if you have a very small entrance to the submucosal space, then you can create a sort of ventile, and that prevents the CO2 which you use while you are tunneling towards the pyloric muscle to be captured and to form a high pressure chamber, and then you have a higher likelihood of developing a capnoperitoneum or even a submucosal of subcutaneous emphysema. You can choose either a longitudinal or a transverse incision. The longitudinal incision is much easier to close with hemoclips. The transverse incision is more easy to assess the submucosal space in, but I prefer the longitudinal incision. Then the next step is the creation of the tunnel itself, and there are a couple of factors which are important. The location is, of course, dependent on the location where you performed the mucosal incision. But most importantly to mention here is that you really should stay close to the muscle layer, because you can easily get lost in the submucosal space if you don't know where to go. And the orientation of the circular muscle layer of the stomach, of the antrum, guides you towards the pylorus. As long as you move perpendicular to the muscle fibers, you will never miss the pylorus. And if you don't see the muscle layer, then it is easy to miss the pylorus and to have the wrong direction. I always try to save bigger penetrating vessels, as you can see here, through the cap, because those vessels, penetrating vessels, are important for the integrity of the overlying mucosal flap. Small vessels can be coagulated, of course. The ESGE recommends the submucosal tunnel created during J-perm procedure to be at least 3 centimeters in length to secure a safe overlap of the myotomy site by intact mucosa, so not too close to the pyloric arch or the pylorus. Sometimes it can be difficult. This is an example of extreme fibrosis of the submucosal space, and you can imagine that it's very difficult to keep orientation here. I don't know what the exact cause of this extensive submucosal fibrosis was, but it was quite difficult. So it's not always as bright as shown in this example and in the video. Then when you follow the perpendicular direction on the muscle fibers, then you reach the pyloric arch, which is always clearly visible as here. And it's very important to prevent damage to the duodenal mucosa, which is located over here. So you should inject to create a bleb at the other side of the pyloric muscle, so at the duodenal side, and the myotomy is most safely done by a pulling movement. If you hook the muscle fibers and then you pull the angle down the endoscope and you pull, then it's safe and you will not damage the mucosa at the duodenal side. It should be a complete myotomy. I already mentioned that. And the ESGE suggests the length of the myotomy should be 2 to 3 centimeters and should include the pyloric muscle up to its termination into the duodenal bulb. Closure can be done by clips, also by the over-the-scope clip or endoscopic suturing. And then the final step is the assessment of the pylorus, of course, and also the assessment of the integrity of the overlying mucosa. PPI should be administered, a gradual increase in food intake. I personally do not perform a regular control endoscopy at post-operative day 1 because it's very rare to have complications. And if there are complications in terms of leaks, patients will become sick and you will recognize it anyway. Follow-up, well, you should repeat the symptom scores, and I would advise to also repeat the gastric emptying test also to get some feedback on how you achieve. So this is my final slide, and I handle back the microphone to Kostas. Maybe we have got a couple of minutes for discussion. So thanks for your attention so far.
Thank you both. Thank you for the presentation. Thank you for the clarity of the information. Very useful technical information for real life and for attendees and endoscopists that they are trained or keen to perform this endoscopic procedure. We were lucky enough that during the time where we appreciated the presentations of Bas, Jan Martinek answered a lot of questions, and I did answer some of them too. So I'm sure that our attendees are very, very happy. But we have some time for brief question and brief answers, please. One question is for both of you. Okay, a poem is well established. what is the future? What do you anticipate as a future step for POEM, Jan? And a similar question for Bas. GPOEM is not yet established, but which are the next steps, in your opinion? Jan.
So I think POEM is now established and recognized, and let's say standard treatment for achalasia. The major problem is reflux, and we must really look at the results of long-term studies and randomized studies to see whether post-POEM reflux will cause some problems in terms of reflux complications such as Barrett's esophagus or adenocarcinoma. And of course, there is a space, there is really a room to investigate the role of combining POEM with some endoscopic anti-reflux procedure. But this issue is not yet clear. It is really not clear who would benefit from such combined procedure. We know Haru Inoue presented F-POEM, it means POEM plus endoscopic fundoplication, but I think this is the key question. If the reflux issue will not be major, then POEM will have a really nice future because it's very safe and effective. If the reflux issue will cause some problems in terms of late complications, then we will have to reconsider its role in treatment of achalasia. This is, I think, the main issue with regard to POEM.
Thank you, Jan. And Bas?
Now, with regard to the JPOEM, it isn't an established treatment yet because there's too little evidence so far, especially for the long-term results. But I am quite optimistic on the future of JPOEM. But I think there are several issues that should be addressed. First is we really need good quality studies on the effectiveness of JPOEM, but especially on the long term. We also need to have data on the efficacy of JPOEM on the different causes of gastroparesis. It might well be that a post-surgical gastroparesis is another entity and maybe has a different efficacy of JPOEM compared to idiopathic gastroparesis or diabetic gastroparesis. So we should have trials in specific patient groups. And finally, we need tools to predict the response to JPOEM. And the EndoFlip technology has the potential to do that, but there's still some research to be done here.
Okay, and again, two similar questions for both of you. Would it be harder to treat, for example, a patient with achalasia if he had underwent pneumatic dilation first, and in a similar manner, does recurrent botulin Botox injection cause fibrosis and make your life much more difficult? Bas and Jan, what about the troubles of going with POEM after pneumatic dilations, recurrent pneumatic dilations?
In our group of 400 patients who underwent POEM, approximately 15% or approximately 30%, 25 to 30% already undergone a treatment before POEM. It means they experience a recurrence after either PD or Botox or laparoscopic myotomy. So POEM is feasible in such patients, but PD as well as Botox can cause fibrosis and can make your POEM more difficult. That's why, for example, if there is a patient and we are thinking what treatment he would undergo, and we do not recommend to perform PD if the patient is a candidate for POEM. It means some kind of rescue PD, because to do POEM just after PD, let's say 2, 3, 4 weeks after POEM, it's in my view inappropriate because of healing process and fibrosis. But if the interval between PD and POEM is more than 6 months, I don't see a big problem. The Botox really can make POEM more difficult. I would stress not to do repeated BT injection because each injection makes the situation worse. But I really would like to underline that we don't offer botulotoxin to our patients with achalasia as a standard treatment. And if there is a 25 years old patient with achalasia who wishes for botulotoxin, we really try to convince him to undergo either PD, Lap-Mayo, or POEM, not to go for BT because he would need another injection in few weeks or months. So this is, and the reason is not only the fibrosis, but also the short-term effect.
I fully agree with Jan.
And what about G-POEM?
Yes, I fully agree with Jan also for the J-POEM part of the of this presentations. Although I think that the lower esophageal area is more sensible, or is more it might have more negative effects of botulin toxin injection than the pylorus. Personally, I didn't have that much problem with J-POEM after botulin toxin injection, but theoretically, of course, it shouldn't be done because of the risk of fibrosis and making life more difficult. And on the other hand, it is not a permanent solution, so why should you do it? The only reason why you could use botulin toxin injection is if a patient is not fit for any other procedure yet, and you expect the patient to, after half a year, for instance, to get a better condition and then can undergo a J-POEM. So as a bridge to a more definite solution, you can use it. And one injection or one botulin toxin treatment doesn't bother me too much, I must say, at least for the pylorus.
Okay, thank you, Bas. Thank you, Jan. Unfortunately, as always happens, the time goes by. And thank you for the participation and the important information that you provided to every one of us with the clarity. And according to your expertise, it was, I'm sure that everyone enjoyed this webinar. And for the information of our colleagues, this recording will be posted in the e-learning section of the ESGE website, as it happens with past. So in this section, you can find all the past webinar, and you can check them out every time you need it. And of course, it's time to say thanks not only to our participants, but to the governing board of the society that gave us the opportunity for this session. And of course, our webinar team, Dave and Gabriella, who took care of all the technical issues of this webinar. And it's time to remember that if you are not a member, individual member of the society, you should take this advantage by subscribing the sooner possible. There are a lot of interest and yet a lot of benefits of being an individual member. And until our next webinar, which will be next Wednesday actually, about the quality application developed by the ESGE, I will say good night, enjoy the rest of the evening, and au revoir. Bye-bye. Thank you very much.
Bye-bye. Thank you.
Bye-bye. Thanks.
Thanks.
Have a good night.